This is Dr. Michelle Cotty, and today we're going to talk about dissociative disorders. Objectives. Identify predisposing factors for the development of dissociative disorders. Discuss diagnostic criteria for dissociative illness. Formulate nursing diagnoses with goals and interventions for dissociative identity disorder. And discuss various therapies and prevention and treatment of dissociative disorders. Dissociative disorders are poorly understood. It's hypothesized that it results from external trauma, and it divides the memory into subunits. So dissociation is altering one's usual level of self-awareness in an effort to escape from an upsetting event or feeling. So if you're a child and you're experiencing trauma that's really horrific, our bodies want to preserve us into adulthood. And in order to do that, sometimes these children have to go somewhere else in their mind. So they go into this other area in their memory. So it's protective in some circumstances, not in all circumstances. Predisposing factors of dissociative disorders include abuse, emotional neglect, disturbed attachment, and boundary violations. So there have been some studies, one of which is cited in our reference, that states that in most clinical research, child abuse or neglect is reported by 90 to 100% of patients who were studied in examination. So dissociative amnesia for childhood events may prevent such reports by some patients. However, many of the individuals who are physically or sexually abused, it's usually actually quite traumatic abuse. So compassion should be at the forefront of nursing care when we are interacting with these individuals. Perhaps you've driven down a highway and not realized how you got from like point A to point B, or you get lost in a book or a movie or music and you sort of lose track of time. That's like mild daydreaming. Losing touch with conscious awareness of one's immediate surroundings can sometimes occur and be within normal limits. But extreme and chronic dissociation results in dissociative disorders. During a traumatic experience, a person may dissociate the memory and circumstances of the place. It provides like a mental escape from fear and pain of the trauma. So a lot of these individuals have a diagnosis of PTSD as well. Dissociative disorder is a survival technique. It allows an individual to endure hopeless circumstances so that as an adult, they can preserve some areas of functioning. It's a survival technique. It's a mental escape when no physical escape is possible from overwhelming trauma. We always have to have cultural considerations when dealing with dissociative disorders. So a dissociative trance is the awareness of immediate surrounding. It narrows, and a possession trance could be the influence of a spirit, a power, a deity. It's more common in individuals with first-degree relatives who have a dissociative disorder. And from a neurobiological perspective, there's a dysfunction in areas of the brain such as the amygdala and hippocampus. Psychodynamics, it is a defense mechanism against pain of remembering severe abuse. So if you get a chance, you may want to get out your DSM-5 or look at it online and look at the differences and the diagnostic criteria and signs and symptoms of these disorders. For a depersonalization disorder, this is a recurrent or persistent feeling of being detached, like you're observing everything from sort of outside of yourself. So you're detached from one's mental processes or body. Reality testing remains intact, but it can cause significant distress or impair social occupational functioning. In depersonalization disorder, we feel like we're a stranger to ourselves. Common objects and familiar situations seem strange or foreign. This can develop after smoking weed, using ecstasy or LSD. And it would feel like if somebody calls your name, you don't even feel identified to the name. Like nothing seems real. Dissociative amnesia. So this is the inability to recall personal information. It's too extensive to label as forgetfulness, and it usually follows trauma or a stressful situation. It causes significant distress or impairs social or occupational functioning. Dissociative fugue. A sudden, unexpected travel away from one's home or one's customary place of work, and the inability to recall one's past and confusion about personal identity. So this person is lost, and they may even assume a new identity. It usually happens after trauma or stress, and recover is rapid, spontaneous, and complete in most cases. Now let's look at some culture-bound dissociative syndromes. So there's a disorder called falling out. And what this means is an individual collapses after a feeling of dizziness. The person is paralyzed and unable to move, although they can hear and understand. So this is possibly related to stress or trauma. And this is in the ethnic groups in southeastern United States, especially Miami. And it's primarily found in African Americans or Afro-Caribbeans. The evil eye is a magical glance that can send evil to another person. And then the person who receives the evil eye has fitful sleep, so they can't sleep, they cry without cause, they have diarrhea and vomiting, and things can go wrong in their personal life. And this disorder is found in the Mediterranean cultures and in the Middle East and Latin America. Dissociative identity disorder, or DID. This is when an individual has the presence of two or more distinct personalities that control the individual's behavior. Each alter has their own pattern of perceiving, relating, and thinking about the environment, and it's not caused by a substance or medical condition. This is a very rare diagnosis, and it is questionable by some experts if it is actually two separate personalities. So if a therapist, for example, were diagnosing somebody in large numbers, if they were diagnosing lots of people with this disorder, that could actually be pretty harmful, because then the person thinks that they have split personalities and they don't have control over their own outcomes. So this would be a very, 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 very rare diagnosis. People who have dissociative identity disorder can lose periods of time. They may have male or female alters, and the main alter appears more often and knows more than the other. Transitioning from one to another is rapid, and the treatment is long and very challenging. So risk factors for developing DID are severe childhood abuse, physical, emotion, or sexual abuse with repeated trauma, a family history of mental illness or violence, and substance or stimulant abuse. That wouldn't be the cause, that would be a risk factor. Also, a lot of self-harm with these individuals. Cutting skin or burning self with cigarettes can be some of the behaviors that we see in individuals who have dissociative identity disorder. It represents a desperate attempt to try to stop the emotional pain. So just like people have different levels of physical pain, these individuals are very, very sensitive emotionally. So if you've ever stubbed your toe on something and you bite your finger to kind of displace the pain, they're trying to displace the emotional pain internally with physical pain externally. They're trying to get back in touch with themselves in reality, and they actually can commit suicide accidentally. These individuals dislike their body. They have an inability to cope or express emotions to others, frequent mood swings, and may feel unreal at times. So these are personality traits of these individuals. These individuals hurt themselves to feel alive sometimes. Sometimes it's for a euphoric adrenaline rush or a release of endorphins, to feel real when they're feeling numb. And again, it's easier than dealing with emotional pain. Sometimes that emotional pain is from painful memories. So self-mutilation has a common progression. The first incident might be an accident where they see someone else do it. They may have strong feelings such as anger, fear, anxiety, or dread before an event, and these feelings build, and the person has no way to express or address them directly, so no coping skills. There is mounting tension, and when they cut, they experience a sense of relief. So they also, in the common progression, they'll hide the tools and cover up the evidence. Next time the strong feelings come, the person is now conditioned to cut, so now it's behavioral. The feelings of shame lead to continued behavior and compulsions to repeat the behavior, and now the behavior starts to increase in frequency. More symptoms may be visible scars, fresh wounds, blood stains on the inside of clothing, wearing long-sleeved or baggy clothing even in hot weather, unusual need for privacy, so locking themselves in a room for hours. They're hesitant to change in front of others, and they're very defensive when questioned about scars or wounds. Being able to be direct and honest and having good communication is an important skill in life, an important skill in nursing, and a very important skill in psychiatry. So what do you say when you see somebody that has cuts on their arms? Stating a fact is always a good place to start. I notice you have several scars on your arm. It looks to me like you've been cutting. Do you want to talk about that? You might want to express concern that cutting can lead to unintended suicide. Talk about stressors. And sometimes people will deny they've been cutting and continue cutting, but it's nice to also give other coping skills that they can use when they feel like they want to cut. Dissociative disorders. So these individuals may have emotional instability. So they may go from happy to sad to crying to angry in a very short amount of time. They may have anxiety. Some may have psychotic symptoms, hallucinations, and paranoia. And others may also have aggression and out of control behavior. No harm contracts can be used as part of a therapeutic nursing management protocol. We want to establish good rapport, and it's really, really important to have appropriate boundaries with these individuals. Journaling can help work through traumatic dissociative periods. We want to be non-judgmental so that these clients don't have to feel so defensive when they respond. Again, we need to really have a safe environment for these patients. When individuals are uncovering traumatic memories, we want to take note of this and report it back to the prescriber and their therapists. Sometimes if they're being flooded with memories, it can be too much for the individual to handle. And when that happens, we are always concerned about patient safety because suicide risk increases during stressful events. Family support without pressure to remember things is important, and we want to educate both the patient and family about the recovery process as the individuals are going through this. When we're talking about nursing diagnoses, we want to consider ineffective coping and disturbed thought process. And remember, when you're doing a nursing diagnosis, you would want to include possible etiologies. So for example, it'd be ineffective coping related to, so it could be childhood trauma, childhood abuse, low self-esteem, unmet needs, regression, and then, so we'll say related to trauma abuse. So ineffective coping related to trauma or childhood abuse as evidenced by dissociating from painful situation by experiencing part or complete memory loss. So goals for these kind of individuals would be to understand why they dissociate and to verbalize more adaptive ways of coping in stressful situations instead of resorting to dissociation. And the long-term goal is that these individuals would be able to cope with stress instead of dissociating. And then interventions could include things like reassuring the client of safety by being present, because dissociative behaviors might be frightening, and the presence of being near someone that they trust helps them feel safe from harm. So put some thought into nursing diagnoses for individuals with dissociative disorders. So the treatment approach would be interdisciplinary. These individuals could benefit from individual and group therapy. Also things like art therapy, family education is very important, and other alternative methods include hypnosis or eye movement desensitization. The International Society for the Study of Dissociation, selfinjury.com, and 1-800-DON'T-CUT are additional resources. Thank you for listening to this lecture, and here are the references.